Welcome to the final section on our discussion of pediatric pathology and anatomic refreshers. Today we're going to get into the digestive and urinary systems, and we're going to start with the upper GI first. So as a refresher, here we have the stomach. Up here we did have the esophagus, but we're going to kind of skip that for now and instead go right to the esophagogastric junction, or cardiac orifice here. The cardiac antrum is this portion specifically, right next to that junction, and above it, this notch here is called the cardiac notch. The fundus is the most superior part of the stomach, with the rest of it being the body. The inner curvature is the lesser curvature, and the outer one is the greater curvature. Here we see that pylorus, namely the pyloric portion, which has an antrum, a canal, and then of course an orifice here. And down here we see the angular notch. After that we get into the duodenum and so on, but first I want to remind you all of how you can tell a patient's body was positioned depending on where you see air versus where you see barium. Also, another reminder is body habitus. We went over this quite a while ago. As a reminder, it's hypersthenic is going to be massive build, and it's usually anatomy drawn out from side to side, let's say. So we can see the transverse colon here is kind of straight or horizontal, let's say, straight across and along with the stomach, and we see the gallbladder's kind of high. The chest also is kind of broad. Sthenic is more average. Here we see that normal curvature, not normal, but average curvature of the stomach with average gallbladder, transverse colon, and lungs. Hyposthenic's on the verge of asthenic. These two are closely related. Hyposthenic is a less emphasized, I want to say, body habitus than asthenic. But we can see here the stomach is pretty low. The transverse colon is getting down into the pelvis almost, and the gallbladder is more central. Here we see everything is very central, almost vertical, and low in the pelvis. In our x-ray of the lower GI, and now we're getting into the, again, the large bowel, we have the cecum, which is joined from the small intestine up to the right colic flexure, transverse colon, left colic flexure, ascending colon, into the sigmoid and the rectum. The appendix comes off of the cecum. And we also see haustra of the colon. Remember, haustra are pulled together, kind of bunched up with tinea coli, and help the large intestine move contents through. I'm going to let you take a minute to answer a few questions and jog your memory about this x-ray. And then we're going to move on to the pediatric digestive pathologies. So there are just two here. One is meconium ileus. Remember, ileus refers to a bowel blockage. So we learned about mechanical and adynamic ileus earlier in the semester. Meconium ileus is specific to pediatric patients, and it's an obstruction caused by meconium that becomes too thick and sticky. Intussusception is the most common cause of bowel obstruction in children, though, and as a reminder, that's telescoping, or prolapse of one segment of bowel into another section of bowel. As a reminder about technique change, remember, when contrast is used in the GI tract, usually you want to do a slight increase in kVp. All right, the urinary system, we have the kidneys here with the adrenal glands on top. They sit kind of at an angle to the rest of the more central anatomy here. The psoas muscles are on the side. We can usually see those in an x-ray with good technique. But from the kidneys, we have the ureters into the bladder, where we see the trigone, which is a triangle formed by the two ureters entering the bladder and then the urethra leaving. If we go and take a closer look at the kidney, though, we see we have a fibrous capsule before we get to the cortex. Then we're going to get into the medulla, or renal pyramids, before then getting into the minor calyx, and then the major calyx, down to the renal pelvis. So that would be following, let's say, contrast going through from the outside, working in to where it's finally, funneled basically into the renal pelvis and finally the ureter. There's only one pediatric pathology here and it's Wilms tumor. It's a malignant kidney cancer in children, and it may need a little bit higher technique than a standard pediatric technique.